Maintenant, on va présenter la neurostimulation avec Dr. Philippe Richebe. Professeur Philippe Richebe a été gradué en médecine, anesthésie et peine médecine. Puis, il a été à l'université de Bordeaux, Il a obtenu son degré de PhD sur le sujet l'hyperalgésie induite et la prévention de la douleur post-opératoire. Il est devenu associé professeur de 2004 à 2008 à Bordeaux, puis à Washington. Et de 2014 à 2024, il a été nommé professeur, full professeur au Québec. Et actuellement, il s'est réinstallé à Bordeaux, à l'Université de Bordeaux. Ses recherches portent surtout sur la neuroscience, sur l'hyperalgésie induite par les opioïdes, la nociception. Il a à son encontre plus de 150 publications internationales. Monsieur Philippe, je vous laisse la parole.
Good morning. My name is Philippe Richebe. Thank you for the kind introduction. I'm going to talk about personalized monitoring, the Null Index, the BIS Index, the NIRS, the NMT, mainly on the Null and the BIS because we have only 20 minutes and it's a short time for speaking about all these. So let's travel a lot, and I was trained in France. I worked in Iowa for my postdoc and then moved back to France, and then I moved to Seattle at University of Washington Medical Center. I stayed 6 years there, and then I moved to Montreal for 11 years, and I decided to move back to France in 2024. The reason why I was asked to talk about depth of anesthesia and depth of analgesia monitoring is because we've done a lot of research for the last 10 years on these topics, but also because we just wrote in 2024 an article that was published in Anesthesia Analgesia that you can see here and that I invite you to go and read if you want to. Let's start with the nociception monitoring. Why shall we monitor nociception during surgery will be the first point. Then we will see the validation of the devices, the clinical impact, and the conclusion. So why shall we monitor the nociception during anesthesia? We know that if we have excessive analgesia and if we have insufficient analgesia, the two conditions lead to poor postoperative recovery, and we want to avoid these side effects of excessive analgesia or insufficient analgesia. So we need to find a way to precisely administer opioids and analgesics during the surgery, titrated to the need of the patient and not to classical parameters. The classical parameters that we had so far were heart rate and arterial blood pressure that we were using to guide the administration of opioids, but we know that they have poor sensitivity and specificity to detect pain and so to treat pain during anesthesia. So we need to get better monitoring in analgesia during surgery. And we know that if we have too high level of nociceptive inputs and too much of opioids during surgery, we increase the risk of pain sensitization at the CNS level, and we increase the risk of developing PPSP or chronic pain after surgery. There are a lot of meta-analyses which are already 10 years old, showing that if you use too much of opioids, you will induce opioid-induced hyperalgesia, and as a consequence, higher pain level and higher opioid requirements after surgery. This is another example showing that if you use studies who used low remifentanil have no IH, and studies who used high level of remifentanil intraoperatively have a high risk of developing OIH and acute pain after surgery. This is a nice review that I reviewed many years ago, 5 years ago, and I invite to know more about opioid-induced hypersensitivity. So what we must expect from a nociception monitor is something easy to use, fully validated, more sensitive and more specific than classical heart rate and blood pressure, robust in the OR, and that provides me information that my human eye cannot see and cannot assess. It must offer continuous evaluation, and I like this continuous evaluation because if you don't have a continuous evaluation, it means that you miss events and you do not detect some events and you do not appropriately administer opioids. It must be fast to react, and it must also detect the effects of the analgesic drugs that we are giving. It must allow precise administration of analgesic during the surgery. It must significantly reduce pain and opioid requirements after surgery, and must speed the recovery of the patient after surgery. So are they validated? And that's an important point. We don't want to use something that is poorly validated in the OR. The pupil diameter, I like it. It's fine, but it's not a continuous evaluation. That's why I stopped using this one, because it's not a continuous. Skin conductance, SSI, surgical stress index based on plethysmography, and ANI based on EKG and variability of the heart rate are monitors that are validated and that are on the market. The last one coming on the market is the Nol index. I love this one, and I'm going to talk about this one mostly because it's a multiparametric evaluation based on heart rate, variability of the heart rate, skin conductance, temperature of the skin, variation of these two parameters, and the amplitude of plethysmography. And because it's newer than the other ones, there is an AI algorithm that takes all these parameters and makes an index between 0, no pain, and 100, maximum pain. And you can follow it every seconds, every 5 seconds on a screen that provides you the quality of analgesia that you are providing to the patients during anesthesia. This is the setup we have at Maison de Rosemont Hospital, the Nol index, the BIS index, the muscle relaxation also, and the classical parameters. Validation studies are key and important. We published one in 2019 based on a very specific a very specific and very precise research protocol, looking at intubation, surgical incision, and different painful stimulation, which are post-tetanic count, electrical stimulation represented by the red arrows. For each of these clinical or experimental stimuli at different doses of remifentanil, we have the pre and post values of the Nol index, heart rate, mean arterial pressure, BIS index, and we transfer all these into a ROC curve to tell us what is the sensitivity and the specificity of each parameter. And you can see the blue one, the Nol index, is much better than the red and the green ones, which are blood pressure and heart rate. So it's more sensitive and more specific than heart rate and blood pressure, and it does a better job in terms of detection of nociception intraoperatively. This is true in different studies: Anesthesiology 2015, 2016, Canadian Journal of Anesthesia 2019, and another ones we did in Montreal also with the prototype. So it's 4 studies, 3 countries that say the same thing. It is validated, it is more sensitive and more specific to detect pain after uh, after noxious events. So what is the clinical impact? Because it's nice to have an index that does a good job, but it's nice also to see what is the clinical impact of its use. When we use nociception monitors, it does decrease the opioid consumption during the surgery. This study was published in Anesthesiology in 2017 using the pupil diameter evaluation. They showed in gynecological surgery, they showed that they had less intraoperative remifentanil usage when in the pupillometry group, and they had less morphine consumption after the surgery. This one was in spine surgery, published in 2017, using the ANI index, and they showed in this type of spine surgery that by using the ANI index intraoperatively, they could decrease postoperative pain and postoperative opioid consumption was fentanyl given in PACU, and they had a significant reduction of opioids and pain scores after in PACU. This one was published in 2019 from Netherlands, and they showed in colorectal surgery that by using the Nol index, they could reduce by 30% the opioids intraoperatively, and as a consequence, they had less hypotensive events and less need of vasopressors during the surgery, which means that they did a much more stable anesthesia with less need of opioids intraoperatively. They came back in 2020 in British Journal of Anesthesia, showing that by using the Nol index, they could also reduce postoperative pain levels and postoperative stress hormones such as ACTH and cortisol, meaning that they had not only an impact on intraoperative opioid consumption, but they also had an impact on postoperative pain and postoperative stress for the patient. And here you can see on the left the trajectory of pain in PACU, in purple for the standard of care group, and in blue for the non-index group, meaning that there is less pain in PACU when you use the non-index intraoperatively. We did one study that we published in 2021, end of 2021, in gynecological surgery, showing that by using the null index with the opioid fentanyl given intraoperatively, because we still use a lot of fentanyl intraoperatively in Canada or in North America, we could reduce by 25% the amount of opioids given intraoperatively in gynecological laparoscopic surgery. And we also could decrease pain scores and opioid consumption by 40% in the PACU. We also could detect the analgesic effect. You can see the blue and red curve here, surrounded by the red circle. This means that the null index was able to detect the analgesic effect of fentanyl, whereas heart rate and blood pressure were not able to detect the analgesic effect of fentanyl. So using these nociception monitors, you can also predict what is going to happen in PACU. This was published in BGA 2013. They used ANI index, and they showed that by using ANI, they could predict pain scores in PACU. This comes from Australia, showing that the null reaction to incision and also the average null during the surgery were predictive of postoperative pain in the PACU. And we did the same thing, new analysis of our null gene study showed that the null after intubation, the median null during the surgery, and also the percentage of time spent with null above 25 were correlated with moderate to severe pain in PACU. So the better you manage null index intraoperatively, the less risk you have to develop pain in PACU. So as a conclusion, there are many devices that are available in 2024 to monitor nociception. Continuous evaluation for me is key. They discriminate nociceptive stimuli better than classical heart rate and blood pressure. They help titrating intraoperative administration of opioids and analgesics. They decrease by 30% the total needs of intraoperative opioids, and they might also improve postoperative pain management. But you need to combine the depth of analgesia with the depth of anesthesia, because if I do a good job with analgesia, but if I do a poor work with anesthesia, then you don't see the benefits of your anesthesia management. That's why we're going to talk about EEG monitoring now. Personalized anesthesia is based on using the null, the BIS, the muscle relaxation, and the hemodynamics data also. And that's what we are going to see with the raw EEG evaluation. Right now, we have the BIS or the Massimo, whatever you want to use. They provide you with a raw EEG that is a combination of different waves, slow waves, less than 4 Hertz, that are delta waves, and alpha waves that are between 8 and 13 Hertz. And we don't want to see in anesthesia rapid waves or very quick waves, such as the beta wave, about 25 or 30 Hertz. My human eye is able to see the red curve, which is slow waves. My human eye is able to see the small peaks of the alpha waves between 8 or 12 or 13 Hertz or spike per second. But then I cannot count that every single minute in my life in anesthesia. So that's why they came with these nice colors. And these colors are showing the concentration of each type of waves with different colors. When it is red, it means that you have a lot of waves on the EEG that are in this specific area. So if I see right now on the left, the BC51, the raw EEG shows alpha and delta waves, and you have delta in the 0 to 4 Hertz on the y-axis. You have delta, which is very red, and alpha, which has like a dark red band. And you have the SEF, the spectral edge frequency, which is also white, the white line, which means 95% of the waves of my patients are below the number that is about 15 hertz now. So 95% of the brain activity is in slow wave motion, and only 5% is in the high frequency band, which we don't want to see in anesthesia. So that's what we call density spectral array, the DSA, and these nice colors provides you with a lot of information in terms of quality of anesthesia for the last hour of your anesthesia. We don't want to see burst suppression, which are represented like suppression and then a burst on the raw EEG. And on the DSA, you can see that the burst suppression are these kind of dark lines that you can see when your anesthesia is too deep. The DSA changes with the brain. I invite you to read different articles on that. The learning curve of using the DSA is quick, so don't be afraid. After 5 patients, you will be able to completely understand what happens on your DSA, and it's easy to use. These are clinical cases. Case 1, it's a 70-year-old man who has hypertension, Parkinson, no cardiac problem, no vascular respiratory problems, no vascular problems. It comes from sigmoidectomy via laparotomy because he has a volvulus. We placed an IV line, an epidural. We gave a GA induction with very tiny dose of propofol. You can see only 50 milligrams for 70 kilos or so, 77 kilos. Remifentanil was 60 mics and rocuronium 100 milligram because he was in semi-occlusion. And then we maintain with sevoflurane and a small, very tiny doses of remifentanil with the epidural and a small doses of phenylephrine. You can see that the MAC of the sevoflurane was 0.4, and we had a BIS at 53, and we had these nice spectrogram with 2 red bands in alpha and delta, which we want to see, and a dark blue in beta, meaning that there is no more high frequency waves on his EEG. So very nice stable hemodynamics despite 0.4 of sevoflurane. He has a BIS and a DSA, which is normal. So we don't want to get too deep, and that's what we want. In case 2, it's a 92-year-old male who comes from small surgery, pancreatic surgery via laparotomy, but is 92 years old and it's supposed to last about 3 hours. We place an IV line, an epidural, again, GA induction with a very small dose of propofol, remifentanil, and rocuronium. He was intubated. He had a very nice DSA. You see the dark blue showing that he has no more beta waves. And the MAC of the sevoflurane is 0.6, and the Nol index was managing the pain during surgery. So we could really titrate the analgesics given through the epidural and through the IV line with the Nol index. We could decrease the MAC to 0.5, 0.6 all along the surgery with a DSA that was completely normal, a red band in delta, a small red band in theta alpha, and no more beta waves with the SEF, the white line that shows that 95% of the brain activity was below 13 hertz. So these patients had a surgery that lasted 4 hours at the end. He was extubated around noon. The surgery started at 8, and you could see that he was brought in the PACU. He had no pain, no PONV. He had no cognitive dysfunction, which is important when you are 92 years old. A very nice hemodynamic, which was similar to the one who he had before the surgery, and he was joking with the nurses in PACU, and the nurses in PACU make the difference. So that's the combination of the two: monitoring of nociception, monitoring of depth of anesthesia with the raw EEG and the DSA that allows you to have this kind of quality of recovery. In terms of neuromuscular blocking NMB, I'm going to be very quick because I have only 1 minute left. There is this meta-analysis from 2017 in BGA showing that if you use deep neuromuscular blocking, meaning you really block your patients with a PTC less than 2 out of 10 intraoperatively, you will improve the surgical space condition, you will improve postoperative pain in the deep group, meaning that if you are deep intraoperatively, from the beginning to the end of the surgery, you will improve postoperative pain profiles. And that's what we also showed in these articles we just published in GCA in the US in 2024, showing that if you use deep neuromuscular blocking, you will decrease remifentanil intraoperatively by about 30%, and you will also decrease, you will also improve pain postoperatively and decrease the opioid requirement after the surgery. So precision anesthesia, personalized anesthesia, needs to use all these new monitors we have in anesthesia to make the best quality of anesthesia. Regarding the NIRS, I don't have time now to do that. So please see the questions in the question session. And I do thank you for your attention, and I'm open to questions. Thank you very much.